Greetings from National Academy of Medical Sciences, India. NAMS has been recognized by the Government of India as a nodal agency for promoting the continuing medical education for medical and biomedical professionals. National Academy of Medical Sciences encourages and sponsors nationwide CME programs, symposia and workshops in medical and biomedical professionals. NAMS is pleased to announce the launching of a joint NAIIMS NAMS Navigate CME program from 1st September 2023 for postgraduate students in all the NAIIMS and other eminent institutes of national importance from Andhra Pradesh, Arunachal Pradesh, Assam, Bihar, Chhattisgarh, Goa, Gujarat, Haryana, Himachal Pradesh, Jammu and Kashmir, Jharkhand, Karnataka, Kerala, Madhya Pradesh, Maharashtra, Manipur, Meghalaya, Mizoram, Nagaland, Odisha, Punjab, Rajasthan, Sikkim, Tamil Nadu, Telangana, Tripura, Uttar Pradesh and Uttarakhand of the country. The program is being conducted online on 1st and 3rd Friday of every month from 3 p.m. onwards. The NAMS-AIIMS PGIMER CME focuses on the topics which are of common interest for the postgraduates across all specialties. The aim of the National Virtual Postgraduate Medico CME is to help them to be more proficient in their profession. Each session will covers 1 or 2 topics followed by questions and answers. Thank you for your kind support.
Hello and good afternoon, everyone, and welcome to the next session of the dental and oral health series. Since we all know that facial trauma nowadays is a significant public health issue in India, out of majority of the traumas, majority of them are caused by road traffic accidents, and we all know that despite having 1% vehicle of the world, we are contributing around 11 to 12% of maybe more than that road traffic accidents. And also other than that, there are cases of falls, then violence, then occupational accidents, also sports injuries. So there are various causes. But since the facial trauma, it has a profound impact on young and the working age adults. So it's very important for us to know about the details of management of facial trauma. So today with us to know about the management approaches of facial trauma, we have very eminent speaker with us, Professor Ajay Chaudhary sir. So without wasting much time, I would like to request the Secretary of National Academy of Medical Sciences, Professor Umesh Kapil sir, for the welcome address. Over to you, sir.
Namaskar and pranam to all of you. My most humble welcome to all the participants and the Professor O.P. Kharbanda and our respected most eminent speaker, Dr. Ajay Rai Chaudhary. Now, we started this Navigate program about 3 years back, and the aim was Navigate means National Virtual Graduate Training Program. Now, what we do in this program is essentially we have about all the medical colleges and in our network, and we organize these online sessions by most eminent scientists in the medical and biomedical field. They come and deliver lecture on common topics which are same for all the specialties, postgraduates of all the specialties and young faculty members. Now, if you look at the national scenario, we have about 120,000 MBBS and BDS doctors who are qualifying, and out of which their maximum of 20,000 PG seats available. And those who are preparing for the NEET examination to get into the PG seat, their knowledge needs to be updated. And we're not talking about the metropolitan cities. We're talking about the most peripheral doctors who are posted in the primary health center, community health center, district hospital, how their knowledge can be updated about the most recent advances in the field of science. So hence we started this Navigate program. It has a benefit that all the PowerPoint presentation are put on NAMS virtual library, which is available on NAMS website. All the presentation live telecast on YouTube. Those who are unable to attend, they can attend and update their knowledge through YouTube as well as through the PowerPoint presentation and live presentation by the eminent speaker. Now, what we have done is there's a 45 to 1 hour session of the lecture, and then it's followed by about 45 minutes of question answers. I personally feel that question answer is the most important part of this Navigate program, because there are issues which I want to ask, but I don't have the courage to ask that question. And somebody asks it for me. And that goes to my hard disk. And that's my undergraduate, postgraduate, and as a faculty experience, that the question answer sessions are very informative. So my humble submission to all the participants is, do ask as many questions as possible, get your queries clarified, so that not only you get benefited, but all the participants who have joined online as well as physically, they get benefited. With these remarks, I close my address, welcome address. Thank you very much. Over to you, Dr. Dr. Jaswant.
Jaswant, please.
Over to you, Dr. Jaswant.
Thank you, sir. Thank you for that address. Now I request our technical team for the message from Professor Digambar Behra. Sir is the president of National Academy of Medical Sciences.
My dear young colleagues, faculty, and officials of the National Academy of Medical Sciences, a very good afternoon to all of you. With immense pleasure, my dear young colleagues, faculty, and officials of this program. National Academy of Medical Sciences, that is NAMS India, it was established on the 21st April of 1961 with the objectives of promoting the growth of medical sciences. It was inaugurated at New Delhi on 19th December 1961 by Pandit Jawaharlal Nehru, the first Prime Minister of India. The NAMS fosters and utilizes the academic excellence of health professionals in the country as its resource to promote excellence in medical education and skill development in the field of medicine and allied sciences. The Government of India has recognized the Academy as a nodal agency for promoting continuing medical education for medical and allied health professionals and is advising the Government of India on several matters of national health policy and planning. The best in the field of medicine are part of this umbrella organization, and who is who of medical science guide the NAMS. The National Academy of Medical Sciences encourages and sponsors nationwide CME programs, symposia, and workshops in basic sciences and applied clinical disciplines. The aim of the National Virtual Postgraduate Medical CME is to facilitate the postgraduate students and young faculty members to increase their knowledge in the medical subjects, to navigate them to be more proficient in their profession and pass their NEET and PG examination to become better doctors, eminent biomedical scientists, teachers, and researchers. As a part of this responsibility, NAMS, in collaboration with the AIIMS New Delhi and 16 other AIIMS-like institutions of the country, has initiated this navigation program in the form of dialectical lectures and discussions. The program is regularly held every first Friday of the month at 3 p.m. The best and useful topics are carefully chosen, and the best teachers from various AIIMS are picked up to prepare and give these lectures. I am sure you all will enjoy these talks and will like them and found them useful in your future lives. Thank you.
Thank you for the message. And now I request for the message from Professor M. Srinivas. Sir is the Director of All India Institute of Medical Sciences, New Delhi.
Namaskar. At the outset, I congratulate the team behind the NAMS-AIIMS Navigate CME program. Providing quality of education to our postgraduate students is one of the prime responsibilities of AIIMS. I know that our able faculty is leaving no stone unturned in achieving this mission. However, there always remains a scope for improvement. Through this unique initiative, there is an opportunity for our postgraduate students to learn from the experts in their field. This learning will go beyond the boundaries of department where our postgraduate students are working and will also bring in more flavor in their knowledge and at the same time ensure dissemination of uniform, high quality content all across the nation. Postgraduate students also form our primary workforce for providing patient care. This indeed is an important component of their training. We are aware that our postgraduate students devote a large component of their time for the patient care services and thus they have less time for self-study by the end of the day. The timing of this activity is therefore very carefully chosen. The sessions will be held late in the afternoon so that the beneficiaries do not have to make any extra effort for attending them. This by itself exudes the philosophy of a true teacher, a mentor that will handhold the children through the process of their active learning. As the sessions are online, which by its very design is a non-synchronous platform, it may seem that the delivery of the content will be one-sided, but enough measures have been planned and they are in place to make the activity as interactive as possible. The topic of the session will be shared with the students well in advance. This will allow them enough time to explore the subject and be better prepared to absorb the content. This design, therefore, also matches the concept and principles of adult learning. The program not only will help our postgraduate students in being better prepared for their examinations, but also will equip them with sufficient knowledge, understanding, and approach to be a better professional in their field. I wish this program all success. Thank you.
Thank you very much for the message. Now it's time to welcome and to acknowledge the special role of the Chief Coordinator for the current series on dental and oral health, Professor O.P. Kharbanda sir. Sir is the Chief Coordinator of the series and also the Director of Delhi Cleft Care Center. Sir has formerly served as Professor and Chief of Center for Dental Education and Research at AIIMS and also Chief of CMET at AIIMS. Sir is also Professor Emeritus and Council Member at National Academy of Medical Sciences. So without wasting much time, and we all are eager to hear to your remarks, sir. So over to you, sir.
Thank you very much once again, and thank you National Academy for allowing us to initiate this series, which is very relevant the topic of maxillofacial trauma is very relevant to the plastic surgeons, to the emergency medicine team, to the maxillofacial surgeons, and anybody who is involved in healthcare because of the vital structures it involves around the face. Quite often, maxillofacial trauma is not in isolation. It is associated with other injuries as well. So therefore, a team approach is needed. And there could not have been any person better than Dr. Ajay Roy Chaudhary, who is heading the oral surgery and maxillofacial surgery department at CDR at AIIMS. With his extensive experience over more than 3 decades, I think we are here to learn from him. And I think thank you very much for joining us, Dr. Chaudhary.
Thank you.
Yeah.
Thank you very much, sir. And I again thank you for your role for choosing best topics for the series and also choosing best speaker for each topic. Thank you, sir. Now it's time to introduce the eminent speaker of the day, Professor Ajoy Ray Chaudhary, sir. Sir is the professor and head of the Department of Oral and Maxillofacial Surgery at CDR AIIMS New Delhi. Sir is the first Indian surgeon to perform TMJ replacement and has been leading in the field in India since then. Also, Sir has been doing path-breaking research through grants from various scientific bodies. Also, Sir is involved in 3D printing and patient-specific implants in orthognathic surgeries, trauma and reconstruction. Sir has many patents in his name and is also international faculty for AOCMF for trauma and TMJ reconstruction. Sir has organized numerous cadaveric workshops internationally and has numerous publications, citations, and chapters in prestigious books like Gray's Anatomy, Bailey and Love. So, with this brief introduction, I again welcome Professor Ajoy Chaudhary, sir. And without wasting much time, I would like to hand over the dice to you. Thank you, sir.
Thank you very much for that generous introduction. Share my screen. Yeah, at the outset, I'm thankful to National Academy of Medical Sciences to give me an opportunity to present my views on the management approaches of facial trauma. These are my disclosures. I have nothing to disclose. I'm not associated with any medical device making company, and I have requisite permissions to show the pictures of my patient with the consent from them. As you know that the facial trauma can exist in isolation, but it is mostly involved with the trauma to the other parts of the body. And always remember that the priority of life is over the limb. That is face as well as far as maxillofacial surgery or plastic surgery or ENT is concerned. So the management must follow the advanced trauma life support principles. Facial trauma, as you know, it coexists with the other polytrauma like head, cervical spine, and thorax. And if you look at the core priorities of advanced trauma life support, airway and spine protection. See, spine protection is the most important one. Then comes the breathing, circulation, disability to rule out the GCS and assessment of traumatic brain injuries, and exposure of the entire body to see if you have not missed any other injuries. Always remember that the facial injuries rarely kill, but the airway compromise and associated injuries do. And if we talk about the ATLS, it will probably take another hour. So these are the basic core priorities which we must know about them. And as such, the facial-maxillary injury comes in the secondary survey when the patient is almost stabilized. And when you look at the maxillofacial trauma, it could be mandible, nasal bones, zygomaticommaxillary complex, maxilla, orbit, frontal bone, nasoethmoidal orbital. They may occur in isolation, or they may occur all together, or maybe two or more together with them. The most common fractures which you see is the mandible, followed by the nasal bones and the other bones. Let us take the individual fractures And then when we come to the end, we will take if all the fractures are present together, how do we manage these cases? Looking at the mandibular fractures, the clinical features are mostly the derangement and occlusion. There is a step defect. There is always sublingual hematoma. The patient has inability to chew food, and there is a radiographic evidence of the breach in continuity, as you can see in the three-dimensional CT scan of this patient. And if we look at the principles of any fracture management, it is accurate pre-injury anatomical reduction, atraumatic operative techniques preserving the vitality of bone and soft tissue, and you provide a functionally stable fixation so that the patient can quickly come back to the mobilization and of its skeletal unit. That is, patient is able to speak, patient is able to chew food, patient is able to talk, rather than getting tied up with the mouth for a long-term period. So these are the basic principles, and these are probably the biomechanical principles of fracture management. And if you look at the fracture of the mandible, it could be treated by closed method, but the closed method would require an immobilization 8 weeks. That means that the patient cannot come back to the function almost immediately, and it will take a long, long time. And these days, nobody can really go in with a tied mouth for 6 to 8 weeks because of the exigencies of life these days. So the contemporary aims are probably the open reduction and fixation. Fixation can be done by semi-rigid or rigid fixation, which do not require tying of the mouth or immobilization or maxillomandibular fixation. But if we are doing it with the wires, then it would require an immobilization. And contemporary aim is not to do immobilization, but to do osteosynthesis. And what is osteosynthesis? It is a surgical procedure to fix the bones together with the contemporary aim that functional stability with early pain-free motion without maxillomandibular fixation, or the old term called as intermaxillary fixation. And the fundamentals are simple, that you structurally augment the fracture to compensate for the load which is going to be there on the mandible during the healing period. And how can we do that? We can do that by means of small plates, small monocortical screws. And as you know, if you look at the tension compression zones in the fractured mandible, and then if you find the neutral zone, you will see that Ciampi and his colleagues, they found that the Ciampi's lines of osteosynthesis. It runs in the intermental foramen. There are 2 lines because of the torsional forces, and posterior to the mental foramen, it is running just apical to the apices of the teeth, going into the shelf area or onto the lateral mandible. And putting the small screws and small plates in this area takes the advantage of the biomechanics of the mandible so that the load is shared between the bone and the plate. Alternately, you can use large humongous plates with bicortical screws placed on the lower border of the mandible, which will disregard all the biomechanics of the mandible and will bear the load completely. So much so that, you can actually bridge these areas with a large plate, and they will take up the load. Even the defect fracture can be dealt with that. But most often, which we are using is the load sharing, that is the small implants. The larger implants, when we use, they bear all the loads. The smaller implants with monocortical screws, when we use, they will share the load with the existing mandible or the shelf of bone, and a little bit of load being shared by the plates and screws. This will allow a functional stability to the fractured jaw so that it can function almost immediately. Let us look at the treatment for the symphysis and the parasymphysis fractures. Yeah, these are the basic principles, that you're using only small plates which are separated about 5 millimeters apart from each other. And because most of the load which is being put on the mandible is shared by the large shelf of bone of the mandible, which is fractured, and a little bit of load is shared by the plates, and this is causing a functional stability. These are called as a load-sharing osteosynthesis, and these are the ones which we use mostly in the intermental foramen region fractures, which is symphysis and parasymphysis fractures. What you do is that you reduce the fractures, you put the patient into intermaxillary fixation, you put in the plates, you suture it back, and then you remove the intermaxillary fixation, and the patient can function almost immediately. I would not say that he will start chewing food, but his mouth will open and he can have probably liquid diet for some time, and then semi-solid, going gradually up to the solid diets. And there is no need to put in intermaxillary fixation for more than 4 to 6 weeks, as has been done routinely earlier for the earlier treatment or the close treatment principles. Yeah. If you look at the angle fracture, and as you see, because you've seen that the Champy's osteosynthesis lines runs on the shelf area or in the lateral surface of the mandible, and it is imperative and it is really pragmatic that we use Champy's small plates, which gives the incidence of infection complications to about 5 to 10%, which is far less than the other treatment modalities which have been used for the angle fracture. And what we do is that if we look at the example, there is a fracture of the angle of the mandible, fracture of the symphysis, parasymphysis in the canine region. The parasymphyseal fracture is treated by a load-sharing osteosynthesis by exteriorizing the mental nerve over there, and then the angle fracture is treated by putting the plate on the Champy's osteosynthesis lines, which is on the buccal shelf area, and a propeller kind of a plate is put so that the patient can function almost immediately and have a good functional stability of the jaws which were fractured. Sometimes when you have a large displacement or a dislocation, then you require a bit of more fixation for the stability. In this, you may use 2 plates because if you don't have enough bone on the buccal shelf area, you can do it via transbuccal trocar, and there is no need to go extra oral in this. All you have to do is to put a hole there and a transbuccal trocar, and put the plates onto the lateral surface of the mandible. You can put 1 or 2 plates as shown in this case, and then you can see that only a monocortical osteosynthesis gives you a very good result in the follow-up. But what happens when the mandible is fractured in a multi-piece? That is, you have a symphyseal and an angle fracture, or a bilateral angle fracture, or bilateral condylar fracture with a symphyseal fracture. Then the whole biomechanics goes haywire. In this case, you will always have to do the anterior fracture into a more rigid kind of fixation by using probably bicortical screws or using a rigid reconstruction plate for the anterior fractures, so that the entire fracture is converted into a linear fracture of the angle of the mandible. So what you do is that, if you see the example of this case, is a bilateral angle fracture and a symphyseal fracture. What you do is that the anterior symphyseal fracture is treated with a rigid manner by reconstruction plate and a bicortical screw, and the posterior angle fractures are treated by small mini plates, either tied put on the lateral surface of the mandible or onto the buccal shelf area onto the other side, so that you can have an almost uninterrupted bony healing in these cases. You would see that you would put in the arch bars there, and you would put the arch bars. Should there be any problem with the occlusion in the follow-up period, you can always go in and put in some elastics and do an intermaxillary fixation should this not work. But more often than not, if the fracture reduction is done properly, this is the only treatment which is required, and the patient can function immediately. But the load sharing is mostly the ones which we're using for the fracture mandible. But is it to be used almost all the time? Probably no. If you have a poor bone quality, that is in the defect mandible or the comminuted fracture, or if you have a poor bone quality, that is in the atrophic bone or the complicated or the infected fractures, and obviously in a non-compliant patient. So when we are talking about the atrophic mandible, we're not talking about the edentulous mandible. We're talking about atrophic mandible, which is a mandible which is less than 10 millimeters in bone height, which is a pencil mandible. And this you will see mostly in the geriatric population. And our population is becoming geriatric very soon, and there is life expectancy is also increasing in these patients as well. So these patients do have a fall, and they do fracture the mandible sometimes. Yeah. The problem is that they have a poor bone and the weak bone stock is there. The vascularity is reduced. Which is mostly periosteal. The neurovascular bundle is at the greater risk. And if you see that, the thin mandible, you have a tension, neutral, and compression zones which are very close to each other. There is a very poor bone contact. but the muscular forces are comparable to any dentate patients in these areas. Besides that, these old and indolent patients have got all kinds of comorbidities, as they may be operated for some cardiac problems, or they may be on blood thinners. And this is a good, I mean, this is a usual thing which you would see, that there you have a big hematoma because of the anticoagulants or antiplatelets these patients are taking, and they have various comorbidities with the fracture of mandible in the atrophic region. The treatment modalities which were used for the atrophic mandible was probably earlier was skillful neglect, that is, just don't do anything, ask the patient to be in the soft diet, or just do close reduction with gunning splints, or the latest ones are the open rupture internal fixation. I would say that there was a paper in 2009 by George Kushner and his colleagues, which suggests that these old and indolent and infirm patients, they don't really do very well using the maxillomandibular fixation with gunning splint, and they tend to actually die of these fractures. And besides that, there will be no union, and these patients would be subjected to repeated operations. As far as the best possible thing could be that you go in and do a definitive treatment and come out. And what is the latest in about the atrophic mandibular fractures is that you use a load-bearing osteosynthesis, that is a large plate with a bicortical screws, mostly in the angle and the symphysis region, where the screw sites, where it will take up the screws. Leave the periosteum if possible, and then bone graft primarily or secondarily. Always remember the saying that the smaller the bone, the bigger the plate. If you see this atrophic mandibular fractures, and you are always tempted to use these small plates and screws, as somebody has used these small plates and screws in these fractures, they will not heal, and they will fracture over time. And somebody is doing this, somebody's making these.
Sometimes they make notes.
Okay. So anyway, so these fractures, these plates will fracture over time. What is really required is that you expose the fracture from the extraoral area. Yeah, you reduce the fractures. You span this area with a large reconstruction plate, and you primarily bone graft these fractures. 30 minutes in and out. But this is a definitive treatment, and you are sure that it will heal. Even if it doesn't heal, this works as a reconstruction plate, and patient can function almost immediately. Yeah, and you can see that in the follow-up period, this is doing fine. And same in this case, in this patient with with many comorbidities and the fracture of the mandible, which is atrophic. Yeah, large reconstruction plate put, and a bone graft, primarily bone grafting is done, and she works. She did very well in the follow-up period. So we did what we know will work, but we please don't do what you hope will work. Coming to the comminuted mandibular fractures, which are often seen in the high velocity injuries of high speed collisions or high speed projectiles, they are mostly open, they are multi-fragments, and they are unstable. Regardless of the fixation system used, they will have a high infection complication rates. The contemporary treatment strategies for the comminuted fractures are extraoral approach, adaptation osteosynthesis for simplification of fractures, and load-bearing osteosynthesis, but no compression. I would tell you what is adaptation osteosynthesis for simplification of fractures. Yeah, you have this comminuted mandible. Okay, you open up these areas through extraoral approach. Then you simplify these fractures. That is, you put in all the fractures together and put in with the small plates there. Yeah, you reduce these fractures and put in small plates to give a shape of the jaws or shape of the mandible. Once this shape or the fracture is simplified to give a shape of the mandible, you span that area with a large reconstruction plate for an unhindered healing. You may want to remove these small plates, that is okay, or these plates can still be placed there. Yeah, so you have simplified the fractures, and you have reconstructed the mandible with a reconstruction plate in these cases. If you look at the example for this comminuted mandible fractures, a young girl who met with an unfortunate thing happened with her, and then she was brought to our red areas where there was a bilateral, because the anterior mandible was totally gone, GCS was low, tracheostomy was done, patient was stabilized. Once the patient was stabilized, we looked into her CT scans, and you can see the multi-piece mandible in the anterior region. Yeah, and if you see that, you see, this is the multi-piece, totally comminuted mandibular fractures here. This was the reason which was causing problem to the airway, for which she was a definitive airway in terms of tracheostomy was done to her. Yeah. So we opened this as per the contemporary treatment modalities. When you open, you saw these multi pieces of the mandible. Then what we did, we tried to simplify these pieces into giving some shape of the mandible. Once the shape came in, we spanned this area with a large reconstruction plate, making it sure that there are at least 2 to 3 screws beyond the fracture line on either side. Yeah. And if you see that she did on the table itself, you can see that the projection of the chin comes back to almost normal. And if you look at the follow-up imaging, and you can see that in the Panorex that there are some segments which are missing. Absolutely, which I said in the beginning, that regardless of the fixation system used, they will have a lot of infective complications, and these small parts can keep out coming. But the good part is that because of the reconstruction plate, they can function almost immediately, and there is an unhindered healing of the bone which can be salvaged there. And she did very well in the follow-up period with no deformity of her face. If you look at the defect fractures, again, etiology could be gunshot wounds, debridement, or surgery. Treatment principles are similar to the comminuted fractures. We use locking reconstruction plates, and you use bone grafting. You see this patient, yeah, this is a defect fracture. The entire defect was spanned with the reconstruction plate. And then you can primarily bone graft, or you can do it secondarily once everything heals up. A secondary bone grafting was done for this patient. Yeah, he did well in the follow-up period. And you can see that there is a very minimal facial deformity, even though there was a large and a huge defect which was present in this patient. Yeah. Coming to the condylar part of the mandible, talking about the condylar fractures, which are very, very controversial as to what is to be done, because there is still no definitive thought about whether the open reduction or the closed treatment works well. But the indications are that the open treatment these days are much better, because they will have these patients will have less internal derangement or osteoarthritic changes in the follow-up period. Yeah. So if we look at the unilateral fractures of the condyle, you will see that there is a premature posterior contact on the affected side. Midline is deviated to the affected side. Yeah. Okay. And if there is a bilateral fracture, which causes shortening of the ramus of the mandible, you will have an interior open bite. The diagnosis is primarily through the radiographs, but the plain radiographs gives us very limited information. So what we do is that the CT scans are the gold standards. And the CT scan, you can see that you can actually see the angulation of the fracture where it has gone, or if it is overlapped medially or laterally, or if there is a shortening of the ramus by more than 5 or 10 millimeters. All the information can be obtained, and a 3D reconstruction can give us indication that where we are going to use our plates and screws, and what kind of fixation, what kind of reduction is required in these patients. The management is mostly sometimes non-operative, because if there is only a linear fracture which is non-displaced, it is there in the place, the periosteal covering or bandage is maintained, you probably do nothing. Just ask the patient to do some small physiotherapy. However, there could be closed reduction, which is always maxillomandibular fixation with the arch bars and screws and elastics. But closed reduction do not cause any reduction of the fractured fragment. It only causes rehabilitation, because the neuromuscular fibers are re-educated to close the jaws in that position. The open reduction and internal fixation is the treatment of choice. But however, because of the facial nerve problems, the surgeons should be very well abreast with the techniques which he is using for fracture reduction and fixation. When we look at the indications of open reduction and internal fixation, there are absolute and relative indications. Absolute ones are the displacement of the condyle in the middle cranial fossa. If there is a foreign body in the joint space, or there is a complete lateral dislocation of the condyle, or if there is no other way, if you can get this proper reduction or occlusion done. And relative indications could be the angulation of the fractures, overlap of the fragments about 2 to 5 millimeters, and angulation about 10 to 30 degrees, severe displacement of the fragments, or in cases of panfacial fractures where it becomes mandatory to restore the lower facial height. When we talk about the open reduction internal fixation, you can use one plate, which has to be a larger plate, or you can do two non-parallel plates, or you can treat the geometric or the hybrid plates, which are available these days. They're very good because biomechanically they are the most stable plates. Let's look at the example of this case. This is a symphysis fracture with bilateral condylar fractures and the maxillary fractures. What has happened, the forces of the mandible in the symphysis has actually caused the flaring of the ramus of the mandible, with condyles getting almost medially displaced or dislocated. Yeah. So what we do is, be on the principles of the fixation, we treat the anterior fractures with a rigid fixation there, that with the exteriorization of the skeletalization of the mental nerve, you can see in the picture. And then the condylar fractures are opened, reduced, and fixed through the retromandibular transparotid approach, that is on the right side, also on the left side by using a non-parallel screws. And these patients do very well. Radiographic, you can see the radiographic and the functional follow-up of these patients, they do very well. And even the aesthetics is maintained. How many plates should you use? One or two plates? Yes, two plates reforms both the tension and compression trajectories and so on. So in cyclic load can be withstand better. If one plate is used, use longer plates or in the larger plates, and probably use bicortical screws. Or else you can use a dynamic compression, which is not available these days, but a dynamic compression screw with the screws in the neutral position can be placed in these. The good thing is that the hybrid plates or these geometric plates are available these days. They are biomechanically correct, and you can use them. They are quick to adapt, and they are very fine. They work wonderfully in the condylar fractures. Coming up to the treatment of the isolated central and centrolateral or the Lefort type fractures, and talking about a little bit about the buttress stabilization. The mid-face buttress system is a system for enclosing the functional units of mouth, that is oral, nasal, and orbital regions. It maintains the position of the maxilla in relation to the base of the cranium and the mandible. And these are the vertical pillars. That is, you can see the medial, lateral, and posterior. Medial one, the nasomaxillary, zygomaticomaxillary, and the pterygoid pillars. And there are many horizontal pillars like the frontal bandeau, infraorbital, and so on and so forth. Yeah. What is important is that these are the ones which will have enough bone where you can put in plates and screws. So we must always member that the reconstruction of the vertical and the horizontal buttresses are important in the midface fractures. There are crumple zones in the midface, because if the crumple zones are not there, then any forces will go directly to the eye and the brain, and these crumple zones, they actually protect the brain and the eye. These areas have sufficient, as I told you, that the buttresses have sufficient thickness, which will accept the plates and screws, and reconstruction is most important. What we need to understand in the midface fracture is that we have to reestablish the anterior posterior vertical position of the maxilla in relation to the cranial base. That is, the facial width, facial height, and the facial projection is to be maintained. Otherwise, there will be a residual deformity of dish faces, of shortened faces, or equine faces, where the face can become actually long in this situation. Yeah. So if you look at the very famous experiment by René Lefort, and he found three particular lines of weakness: those that protect the cranial cavity, number one; number two is those that circumscribe the midface, and those that cut across the midface. So he developed a system of classification, and it is everybody knows that there is a Lefort 1, Lefort 2, and Lefort 3 classification. What is Lefort 1 is probably the horizontal fracture, which starts at the lateral nasal wall and the lateral antral wall. Yeah. And then the lower third of the septum is also fractured, and it fractures the lower third of the pterygoid plates. This is a classical Lefort 1 fracture. If you look at the Lefort 2 fractures, it's a pyramidal fracture. It starts at the nasofrontal suture. The fracture lines runs through the nasal bone along the maxilla to the zygomaticomaxillary suture, and includes the medial third of the orbit through the pterygoid plates, and the septum is also separated. If we look at the Lefort 3, which is kind of a horizontal fracture which causes a craniomaxillary disjunction, yeah, it starts at the nasofrontal suture, along the medial wall of the orbit through the superior orbital fissure, extends along the inferior orbital fissure and the lateral wall of the orbit, goes to the zygomaticofrontal suture. Zygomaticotemporal suture is also separated, extends along the sphenoid bone, separating the pterygoid plates, and the septum becomes separated at the cribriform plate. And even you know that if there is a problem in the cribriform plate, these fractures will have some component of CSF leak in these patients. Yeah. So if we look at the classical features of Laffotte 1, the mobility of the maxilla above the apices of the teeth is classical. The fracture segments are displaced posteriorly and inferiorly. They cause open bite. Segments may be freely mobile or impacted, or sometimes they are immovable. You can see a Guerin sign, which is called as shown as a palatal hematoma in a Laffotte 1 fracture. And when you percuss these teeth, you will find that they will make a sound of a cracked pot in that area, which is very, very distinct from a normal percussion of a tooth in the unfractured maxilla. If we look at the clinical features of Laffotte 2, which is referred to as a pyramidal fracture, apex of the pyramid has the nasofrontal suture, bilateral periorbital edema would be there, or ecchymosis, hyposthesia of the infraorbital nerve would be there, derangement of dental occlusion, probably open bite because of the midface moving downwards and inwards. There is sep defect, which can be palpable at the infraorbital rim. The maxilla is mobile at the nasofrontal area. There could be a possibility of CSF rhinorrhea and epistaxis. If we look at the Laffotte 3 fractures, Pleo Laffotte 3 account to about 9% of the fractures. There is a craniofacial disjunction. There's classical disc facies. Mobility of the zygomaticomaxillary complex is there, accompanying periorbital edema, ecchymosis, and CSF leak, and there could be a traumatic telecanthus because of the fractures at the NOAE region. The accurate imaging helps us to know where the fracture is and how are we going to reduce and fix these fractures, and what fixation system are we going to use. And we can the most important radiographic imaging is CT scans, non-contrast CT scans in these patients, which is nowadays available almost everywhere these days. The goals of management is to restore the anatomy in all 3 dimensions. You plate the anterior maxillary buttresses, you restore the vertical dimensions and the horizontal projection, and you reestablish the pre-traumatic occlusion so that the projection, width, and the height of the midface is maintained. The strategies of repair is that the upper maxilla is stabilized to the frontal attachment, lower maxilla or lower midface is stabilized to the mandible, and then you convert this into a Laffotte 1 and then you plate at the vertical buttresses which are present at the Laffotte 1 areas. Timing of the repair is, it is better that if you can treat these patients in about 15 days from the trauma, because the soft tissues which are displaced because of the trauma will be subjected to repeated traumas after 15 days. So to minimize the double insult, it is always better to treat these patients around 15 days of trauma, or almost immediately is also very good. But many a times there are other life-threatening torso trauma or intracranial injuries which delay the midface fracture treatment in these patients. If you look at the management of Laffotte fractures, you surgically expose that area, you reduce the fragment, you put into a proper occlusion, and then you put a fixation device. And in case if there is any bone loss, you do bone grafting. And because you have done the extensive dissection of the muscles which are attached on the facial bones, you do a soft tissue resuspension. Otherwise, the results, although the bones will be in a proper place, but if soft tissues are not in proper place, the results would not be very good to look at. So if you look at the surgical approaches, it could be intraoral, as in Laffotte 1, or it could be combination of all the anterior approaches. That is intraoral, or it could be the upper blepharoplasty. It could be these transconjunctival or subciliary approaches. It could be brow incisions, or it could be clavicular incisions, or it could be combination of all the ones. But if we have more combination, and we have to really restore the facial vertical width, facial height, and facial projection, we would require a coronal approach. It is required when all the anterior buttresses are smashed. We don't have any areas to start with. You require wide exposure to establish the facial width and the projection. Then after the exposure comes a reduction. How do we reduce that? Because the maxilla moves downwards and inwards, you use disimpaction forceps to reduce, to disimpact the maxilla and slowly make it mobile so that it comes back to a good occlusion. The passive occlusion is mandatory in these cases. If the passive occlusion is not there, then after the reduction and fixation, when you open up the elastics or when you open up the intramaxillary fixation, the patient may end up in the anterior open bite. Make sure that before doing the reduction of the maxilla, there are no subcondylar elements which are present. If there is a subcondylar fractures, you need to treat the subcondylar fractures first and then do the reduction of the midface. Or when you're doing the reduction of the midface and putting them back into occlusion, make sure that the condyles are seated in the fossa and they are not out of the fossa, because that is important, because at the end of the treatment, this condyle which goes back into the fossa can cause anterior open bite. The fixation is done by means of plates, monocortical plates, which are small plates, about 1.5 millimeters are there. You use the buttressing system to put in the plates, because these are the areas where they will take up the screws, because the bone is quite thick in these areas. So 4 buttresses, as you see in the left foot 1, are fixated, or in left foot 2 or 3, as per the fractures which are there, you can fixate these small plate and screws. Yeah. If you look at the patients with the panfacial fractures, you will see that the entire face is like all the metal is there, and you can always ask that, oh, if these gets infected or what, but seldom do they get infected, seldom do they come out. And in case if they get infected, they have done the initial job of causing the healing of the fractures there, and they can always be taken out later. The areas which you can see that there are bone loss more than 5 millimeters. You have already done a coronal exposure. There is a cranial bone graft which is available. Take the bone graft, use the bone graft for buttress stabilization, buttress reinforcement, and buttress replacement. And at the end, which I was saying that the soft tissue resuspension is to be done, because you have done a large dissection of the muscles which are attached to the face. That facial soft tissue resuspension is done especially in the malar eminence, in the infraorbital rim, in the deep temporal fascia, to reduce the diastasis of the soft tissues which move down if you have not resuspended back to their original position. Let's look at this example of a young boy who has sustained a road traffic accident, has sustained classical left foot 1 fracture. We open it from the intraoral incision, intraoral vestibular incision, and then you plate the anterior buttresses to give him a good functional healing in the follow-up period, and with good function as well in the follow-up period as well. Yeah, this is a left foot 2. We have used the large lacerations which were present on the facial on the face, and these lacerations were used to access the fractures. They were reduced and they were fixed at a left foot 2 level and a left foot 1 level as well, and a good functional and aesthetic outcome in the follow-up period. But if you look at the X-rays, or if you look at the 3-dimensional VRT images of the CT scans, you see there are so much metal there. But then that is required to get the bone healing in these patients and almost immediate function. We could have treated that with the closed reduction as well, with the cranial suspension, but that would have amounted to a reduction in the facial height and not good aesthetics, not good pre-injury reproduction of the aesthetics which the patient had. Similarly, left foot 3 fractures, as you see that they are fixed in the areas where the fractures were there. And once you do a proper reduction and fixation in these areas, what you achieve is that you achieve a facial width, height, and projection in these patients. Yeah, so that the initial pre-injury aesthetics and the function is restored in these patients. So if we quickly summarize the midface fractures, the midface fracture patterns have changed. They are accurate diagnosis by advanced imaging to know the complete extent of the fractures is important. You have to use wide exposures of the buttress and the pillars. Stabilization of the facial buttresses will restore the midface height, width, and projection and occlusion. Use the bone grafts if there is a defect of more than 5 millimeters, and always use the soft tissue resuspension. Coming up to zygomatic fractures. Zygomatic fractures, as you know, has got 4 buttresses which are involved in this. That is the frontozygomatic suture, infraorbital rim, zygomatic comaxillary areas, and the zygomatic arch. There is always an orbital component because one of the walls is formed by the walls of the zygoma in the orbit. So the lateral wall can be fractured, or the orbital floor can be fractured as well in the zygomatic fractures. Yeah, the the clinical features would be that patients will have the facial asymmetry, facial width, and there will be cheek flattening, periorbital ecchymosis plus minus crepitus in these areas. There will be a numbness in the second division of the fifth nerve. Lateral canthal dystopia, that is the eye moves in the downward areas. There will be trismus. There can be signs of orbital and the globe injury. The CT scans are the gold standards for the diagnosis of the zygoma fractures. You have to see the CT scans in all the axial, coronal, and sagittal sections. You need to assess the buttresses, and you're looking for combination, you're looking for displacements, and also you have to assess the orbital floor because one of the walls is formed, the zygoma forms the orbital floor as well. The management is guided by CT imaging. That is, you look at the degree of fracture displacement. You see the combination of the buttresses. You see the status of adjacent buttresses, including naso-opmital orbital areas, and you see the status of the orbital floor. Isolated zygomatic arch fractures could be present, and they can be easily reduced from the Gillies temporal approach, as you see in the second diagram, where in the temporal region you go below the temporal fascia, and you put in an instrument which goes right up to the zygomatic arch, and you can reduce that fracture. Does not usually require any fixation, and a small click it will get reduced to its pre-injury status. Or you can do it from the intraoral approach as well, as you can see in the third diagram. But there is a decision to take as to how many buttresses are to be exposed. When is the coronal approach which is necessary? And the coronal approach will be necessary only if there is a combination or outward displacements. Then the question comes in as to how much fixation, as to how many points are we going to fixate? Are we going to fixate or not? Or are we going to do it 1 point, 2 point, 3 point, or 4 point fixation? This is often dictated by combination and severity and the displacement after the fixation, which we keep looking at it. You fix one area and you see if it is getting displaced, you fix the another area as well. When do we explore the orbital floor? Okay, there is a ballpark figure as to say that whenever the fracture line extends medial to the infraorbital nerve, and when you see a fat herniation in the CT scan, it is always advisable, it is always prudent to go into the orbit and just explore it if there is a fracture there, or if there is any entrapment of the fat or the muscle which is happening, which is causing the problem to the eye. And the effects of the disability would come later, where patients will go in for enophthalmos, or they will have diplopia, or they will have reduced ocular mobility. So single point fixation is used usually at the zygomaticomaxillary buttress area, where there is minimally displaced fracture and rotation. There is no displacement in the FZ area or the lateral wall, and these are the simple fractures. Just open up, reduce, and put in the zygomaticomaxillary buttress. 2 point fixations are used in the frontozygomatic and zygomaticomaxillary buttress, where there is combination present in one, but not both the buttresses, where there is no indication for orbital floor exploration. And 3 point fixation is FZ and zygomaticomaxillary buttress and the infraorbital rim, where combination of the buttress, often outwardly displaced arch is there, high velocity injury and loss of soft tissue support. And there is also a need for orbital floor exploration. And the 4 point fixation is used mostly in the panfacial fractures. Let's look at this high energy zygomatic fracture patient. Yeah, his right zygoma is fractured, multiple pieces. His left zygoma is also fractured, but undisplaced. Okay, he also has a concomitant Lafort maxillary fractures as well. You can see the orbital dystopia. The orbit has gone down. It's moved down with the zygoma. What we do is that we have to expose all the articulations of the zygoma. You place the wires in all the sutures to temporarily stabilize them. You check the maxillary buttress for appropriate position. You start at the root of the zygomatic arches, and those zygomatic arches are known as arches, but you need to make sure that the arches are flat for the projection. And you visualize the sphenozygomatic suture as a key point alignment. We'll show you that quickly. Yeah, and how do we expose all the buttresses or all the articulation of zygoma? We take a coronal approach in these patients. Once you take the coronal approach, you reduce and fix the zygoma into a proper place, which gives a proper width and projection to the face. As you can see that the arch is fixated and arch is absolutely straight. Then the diagram, which is showing the sphenozygomatic suture, this is the gray area. And since you have exposed it to coronal, you can go in from the coronal area and see the roof, and you can see the sphenozygomatic suture. And if that is reduced properly, you know that the projection and the width of the zygoma is there, and zygoma is reduced and fixated in the proper pre-injury position. Once the zygoma is done, then you go into the orbit through a subciliary or a transconjunctival incision. The orbit is explored, and the floor, which requires some kind of fixation or some kind of repair, is also repaired with a titanium mesh in these patients. Yeah, and then ultimately the Lafort fractures are treated by plating in the buttress area. Yeah. This is you can see that the soft tissue resuspension has been done, especially in the malar arch area. And you can see that 2 non-resorbable sutures are placed there and tied from the malar eminence area into onto the cranium, which you can see these two sutures there. If you look at this preoperative and the follow-up images, you can see that the bizygomatic width is nicely restored. The patient's aesthetic is restored, and everything looks absolutely wonderful in these patients. This has become possible only because all the articulations of the zygoma were exposed, and they were reduced and fixed properly. That should be the contemporary aim to treat any fractures of the facial skeleton. So the zygomatic fractures, they comprise the wide spectrum of injuries from simple to difficult ones. The treatment is tailored with each individual. Precise anatomic reduction and stabilization is the goal to reduce the secondary deformities. And secondary deformities of the zygomas are very difficult to manage because you need to do a zygomatic osteotomies to get the zygoma back into proper position. If you look at the orbital wall fractures, which always show periorbital bruising, they will show conjunctival hemorrhage and enophthalmos. That is the eye looks sunken in these patients. The visual acuity which changes. There is extraocular mobility restrictions causing diplopia in these patients. There is infraorbital paresthesia, and there is pain on eye motion. When you have to evaluate these patients, you look at the extraocular mobility. You see in the 9 gauges, superior, downward, lateral oblique, and all those gauges, and you see if the eye is moving properly or not. Because any incarceration of the muscle or any entrapment of the muscle in these fractured area will cause a reduction in the eye movement, and then it can also cause some kind of diplopia as well. Ophthalmology consultation is required for all the patients preoperatively and postoperatively, because about 40% of the patients will have other ophthalmological injuries as well. Diagnosis is purely through CT scans, and when you look at the axial cuts, you will see that the lateral and the medial walls are there, and you can also see the shape of the muscles which are there. And if any of the muscle gets incarcerated, this shape changes, and you can see the fractures as well. And if you look at the coronal cuts, if you compare both the orbits, you can see that the orbital floor is fractured, and even the muscle which should be a pear-shaped actually becomes a vertical muscle here. Yeah, so you know that there is some incarceration of the muscle. There is a large volume defect in the medial wall as well as in the floor of the orbit. And if you look at the sagittal cuts, this floor should be a lazy S. This lazy S actually goes, and this becomes like this, and the entire elements or the fat and the muscles, they actually go into the antrum here, and you can see that there is a lot of incarceration of the muscles which are happening. So any floor which is about 50% defect, that warrants repair. How do we repair that? We repair it by bone grafts, or by contourable titanium meshes, or by anatomical titanium meshes, porous polyethylene nylon sheet. The ones which are shown in the red are the ones which have got evidence in the literature that they are the best floor repair implants which are to be used. The bone grafts will resorb over time and cause enophthalmos again. Porous polyethylenes can cause some kind of infection. Nylon sheets are too thin because the eye will again sunk in into the antral area, and it will not have a good floor repair or floor repair in the volume correction. So these patients are sent to the ophthalmology, and you do in-ophthalmos measurements. And if you see that the difference between the two eye is about 2 millimeters of in-ophthalmos, and anything about 2 millimeters of in-ophthalmos actually shows on these patients, and they have to be repaired. So anything equal to 2 or more than 2 warrants an operation. You do a diplopia charting for these patients by means of Hess charting, and you see that there is some amount of diplopia in these patients. Yeah. And then you do the volume estimation. And if you look at the right and the left eye, there is a increase in the volume of the right eye by 3 centimeter cubed. You do the volume estimate, and this is done by some specialized softwares which we have. You can do it by any other digital software, which digital imaging software which you are using there. Then what we do is we print the 3D models of these orbits. What we do is that the normal orbit is mirrored on the abnormal orbit, and we print the still files of these patients. Once we do that, then onto the normal eye, which was mirrored onto the abnormal eye, we adapt the plates so that these plates will actually mimic the original position of the eye which was not fractured. Okay, then you go into the eye through subconjunctival or through a transconjunctival or subciliary incision. Once you do that, you repair the floor and the medial orbits. Yeah. You perform you have to perform a force reduction test preoperatively and postoperatively. You hold the two ends of the muscles there, and you move the eye all around to see that if there is any entrapment. Any entrapment will not let you move these eye in all the directions. Yeah, this has to be performed preoperatively to find out if that is moving properly, and also post implant placement so that there is no implant which is impinging onto the muscles. If you look at the post-operative volume correction, you see that the volume correction has happened. Everything looks fine, and the floor is now nice, lazy S-shape, and the posterior limit of the implant is at the posterior ledge of the posterior ledge, which should rest there. If it is not there, then you've not done a proper good floor repair. If you look at this patient, the 19-year-old young boy, left orbital flow fractures. There is no movement restriction, but he has diplopia in all the gazes. His in-ophthalmos is 2 millimeters, which is present. Left infraorbital nerve paresthesia. Okay. So we do a diplopia charting, and by Hess charting, you see that there is diplopia all over in all the gauges. The in-ophthalmos measurement is there, and about, as I told you, it's already 2 millimeters, but it is really showing on the patient. Yeah. And the volume, you see that the affected eye is more than 4 cubic centimeters, which is more. So definitely there is an element of in-ophthalmos as well as there is diplopia in these patients. Yeah. So you go in, you see that there is some muscle incarceration. You reduce you remove those incarcerations, and you repair the floor by the normal titanium mesh which is available, or anatomical titanium mesh which is available. Yeah, and you see that in the follow-up in the post-operative volume correction, which is almost corrected properly. And if you look at the sagittal sections, the posterior limit of the mesh is at the posterior ledge and nicely stable there. And if you look at the follow-up, there is a nice, good correction which has happened in this, and even the diplopia corrections were there, but they don't happen almost immediately. It will take some time for the diplopia correction to happen in these patients. So the principles are that you must get the rims first, that is, do open reduction internal fixation of NOE and the zygomaticomaxillary complex, and then correct the walls, and then go into the orbit. You expose all the edges of the orbital wall defect, then you place the appropriate size implant. Posterior limit should be stable at the ledge. You may choose to fixate the implant with the screws to avoid the displacement, or it can lie there and doesn't really displace us. Yeah, the complications could be the persistent diplopia. There could be in-ophthalmos, which is there. There could be vertical dystopia, scar-led deformities, mydriasis, blurry vision, or cranial nerve third injury. Could be blindness as well, paresthesia, and all these could be a complication of orbital wall repair as well. The pearls are to get the diagnosis right by using history, physical examination, and CT scans, correct the displacement of the orbital rims, give the lazy S contour to the floor implant. The posterior limit should rest on the ledge. perform post-duction test always preoperatively and postoperatively. Coming to the nasoethmoidal orbital fractures, we are talking about this region, which contains the orbital wall, the ethmoids, and the nasal bones. And you can see that this is a very, very difficult area and it is a challenging area to treat and also causes a lot of problems in these patients. Why this is important? Because it causes traumatic telecanthus. And traumatic telecanthus is definitely not a very aesthetic thing to look at in these patients. Yeah, you see that the eye has moved, intercanthal distance has increased. Why that happens? Because the medial canthal detachment occurs. Once the medial canthal detachment occurs, the eye moves almost on the sides, and you can see that there is a flattening in the nasal bone areas causing traumatic telecanthus. The classification of the NOE fractures are simple: class 1, class 2, and class 1 are not difficult. They're very easy to treat because it has got a large fragment and the medial canthal is not detached. The class 2 is also not difficult because there is a large fragment of bone which also contains the medial canthal, which is not detached. But the challenging ones are the class 3 fractures or type 3 fractures. The type 3 fractures have detachment of the medial canthal ligament. So you need to go in, find out the medial canthal, identify the medial canthal ligament, then you have to tie it to one of the bones on the orbital wall, and so that the traumatic telecanthus is repaired. How do you know that the medial canthal detachment has occurred? You do a bowstring test. That is on the lateral traction of the canthus, where you give the acuity of the medial canthus changes. If it is acute, there is no problem, but if it is rounded, then you know that the medial canthal ligament has detached. You look at the CT scans, and CT scans will give you an exact and a true indication that yes, there is a disruption in the medial canthal ligaments and the orbital walls in these areas, and the nasoorbital fractures are there. They may also have some element of CSF rhinorrhea in these patients. So the 8 key steps in sequencing for the NOE fractures are surgical exposure, identification of the medial canthal ligament and tendon, bearing the bone fragments, reduction and reconstruction of the medial orbital rim, reconstruction of the medial orbital wall, transnasal canthopexy, which is very difficult procedure to do, reduction of the septal fractures and nasolacrimal duct repair, nasal dorsum reconstruction and augmentation, and soft tissue adaptation. So the most useful approach for the NOE fractures is the coronal fracture, where you can actually see both the eyes nicely. You can find out the medial canthal tendon and then repair it and use the wires to repair and bring it closer to each other to reduce the intercanthal distance. You identify the medial canthal tendon and tendon bearing the bone fragment. Once that is identified, you reduction and reconstruction of the orbital rim is done. Reconstruction of the orbital wall is done by means of putting a titanium mesh or even a bone graft if it is possible. And then once that is done, then you can see that the small plate is cantilevered there, and medial canthal tendon can be tied to this. But the way we do it is that we do a transnasal canthopexy. We go from the other side, which is the normal side. You go across the ethmoid areas, and you go into the fractured orbit. You tie the canthal ligament to one of the sutures. That suture is tied to the wire. That wire is brought to the normal side of the eye and tied to the frontal region. We'll show you how it is done. Yeah, you can see that the wire which goes from the other side goes into this area. The canthal tendon is attached to this wire, and this wire is attached to the area in the frontal bone area. Okay, this is a classical transnasal canthopexy. And you can see that it is done bilaterally in this patient. You can see that it is done through the coronal approach. Once we go from this side, and this canthal ligament is tied here, and this canthal ligament is tied on this side to have a good aesthetics in the follow-up period. Sometimes you can do a good job, but to do a good job, once is the best time. The first time is the best time to do a good job for a transnasal canthopexy. You can never replenish. You can never redo the thing and try and think that you will get a good aesthetics in these patients. Okay, then you do the reduction of the septal fractures and the nasolacrimal duct. In case of the duct you think that the duct is blocked, What you do is that you create another opening so that the lacrimal secretions keep passing from there into the nose. Otherwise, these patients will have to undergo a DCR procedure later on. Once that is done, the nasoethmoidal areas will have a combination of the nasal bones and all these projections of the nose. All you have to do is that don't try to reduce these areas, always bone graft these areas and cantilever it to the frontal region. Okay. Once that is done, the soft tissue is bolstered. You put either metal or lead splints, or you can put plastic splints as well. Make sure that you don't over tighten these areas so that the skin necrosis do not happen. That was the NOE fractures. Now, once all the fractures are there in these patients, that is the mandible fracture, the NOE fracture, the maxilla fracture, the zygoma fracture, the frontal fracture. When all the fractures are present, that is called as the panfacial fractures. A fracture of two or more of the facial units. The fracture is the face is upper third, middle third, and the lower third. The three areas of the facial skeleton: mandible, midface, and the frontal bone, including the skull bases and the four facial units. What are the four facial units? The frontal unit, the midface, the occlusal unit, and the mandibular unit. Yeah. Extended midface fractures combining of two or more anatomical facial areas are referred to as panfacial fractures. The classical round and flat face is the hallmark of the panfacial fractures. There is extensive disruption of the fractures of the facial skeleton. There is instability and deformation of the entire face. Overlying soft tissue, they are actually rounded, and there is less angular shape which is there. There is combination of the NOE areas causing traumatic telecanthus. There is orbital zygomatic flattening. There is orbital and nasal cavity disruption, bigonial and bizygomatic widening. There is loss of facial height. The goals of treatment remains almost similar, because we need to restore the facial form, and we need to restore the facial width, height, and projection, and that is achieved through three-dimensional repair of the facial buttresses which are present on the face. Yeah, but where do we start? Because the entire face is fractured. So we need to have a particular sequence of fracture repair. Otherwise, we will miss one of those fractures. And we may even not reduce these fractures properly, which is each and every bone is in relation to the other bone. Yeah, we may not reduce this bone properly. And then ultimately, when we have done the entire operation, the facial width, height, and projection is not maintained, and the patient is not close to what he was in the pre-injury status. So what do we do? There are reduction strategies which are available. It could be bottom to top, top to bottom, inside out, or outside in. The ones which I like to use is subunit principles given by Manson. And I divide the face into various subunits. And these subunits are the cranio-orbital zygomatic unit and the maxillomandibular subunit. But they are repaired independent of each other, stable to unstable in each subunit, complex fracture patterns simplified at the Lafort 1 level, which is repaired last. So you understand that the cranio-orbital zygomatic unit, which is shown in the red, and the blue is the maxillomandibular unit. You can start anywhere, either from top or from the bottom. But you have to end up at the Lafort 1 level. And Lafort 1 level is the one which you should be repairing last, because all the other problems or all the other minor problems of the reduction in these areas will be actually camouflaged at the Lafort 1 region. So it will not really show up. The sequence of repair would be either you start from the bottom or you start from the top. You work towards the Lafort areas. True strategies are based on where you are starting. If you're starting at the top, it's called top down. If you're starting at bottom, it's called bottom up. Okay, so let's look at the bottom up sequencing. Reestablish the maxillomandibular subunit first. Anatomical reduction of the mandible and establishment of maxillomandibular fixation restores the occlusion and the lower height, width, and projection. But in case if there is a condylar fractures of the palatal split, you have to do these fractures first. Okay, so now what has happened is that we have reduced the fractures of the condyle, we've reduced the fractures of the palate, and we have reduced the mandible, we have done the intermaxillary fixation. The maxillomandibular unit is actually done here. The lower unit is done. Okay, and I was talking about the caveats which are there. That is there is palatal fractures. You have to reduce the palatal fractures first and the condylar fractures also before doing the maxillomandibular fixation and the reduction of the mandible fractures. Okay, if you have not done the mandibular condylar fractures, you can still get a good occlusion, but there'll be a shortening of the face. And you see that if the condylar fractures are treated nicely, then the face attains its height, width, and projection. So maxillomandibular unit is done. Yeah, as you can see it here nicely, you can see this dummy on the second pictures. This is a dummy which I've shared with you. Yeah, you can see that the maxillomandibular unit is done. Now we move towards the top-down sequencing. We reduce and fix the cranioorbital zygomatic unit. Again, we start from the less fractured area. That is mostly the zygomatic areas are the less fractured areas because NOE will have a lot of combination. So we start from outside in. Anatomical reduction starts from the side region or with the areas of least combination. Zygoma restores the midface width and projection. NOE complex restores the central facial projection and intracanthal distance. This dummy is showing that the outside zygoma is nicely reduced so that the bizygomatic width is done. And once that is done, and that is done only by means of coronal approach, which you have taken here. After that, you do a nasoethmoidal orbital fixations. Yeah, and once that is done, so at the end of this sequencing, we have cranioorbital unit is also nicely reduced and fixed. So what we have done is that we have kind of converted the entire facial fractures into a Lefort-1 fracture by fixing the cranioorbital unit and the maxillomandibular unit. Once that is done, then it is reduced at the Lefort-1 level by using the fixation in the buttress systems, anterior buttresses which are present here. So and again, the system of the thing is that if you have more than 5 millimeters of the bone loss, any areas, you do a bone grafting in these things. And then once that is done, you go into the orbit, you go into the nose, you bone graft these areas, or you repair it with the titanium meshes. Once that is done, then you do a soft tissue resuspension in the infraorbital, in the malar, in the deep temporal fascia. Okay, let's look at this case. Yeah, is panfacial fractures, and if you can see the VRT images, almost all the bones of the maxilla are fractured, with the mid-palatal fracture, with the bizygomatic, Lefort-3, mandible. Thankfully, the condyle is not fractured in this patient. Yeah, and as I told you that if there is a palatal fracture or the condylar fractures, the palatal fracture takes a precedence. So we reduce the palatal fracture first, and then do the mandibular fractures. Again, maxillomandibular unit done, put in the patient into the maxillar fixation. Okay, then we move to the cranioorbital unit in the zygoma. Once the cranioorbital, when the zygoma is placed into their proper position by looking at the sphenozygomatic sutures and the arch and the frontozygomatic suture, they are in their proper position. The bizygomatic width is restored. Once that is restored, yeah, you move on to the NOE areas. The NOE telecanthus, everything is repaired nicely and reduced. So the entire facial skeleton is converted into a Lefort-1. Obviously the infraorbital rim fixation is also done. Once that is done, the entire fracture is converted into a Lefort-1, and then a Lefort fixation at the buttresses is done. And if there is any bone loss, it is bone grafted. So what has that done? That has given a nice projection, height, and width of the face. And if you can see that there is a lot of metal in the face, but that has really restored and given him the functional endpoint of a good occlusion and a good aesthetic endpoint of the facial face, which is almost near to its pre-injury status. So the complex injuries that involves the fractures at the multiple levels, the goal is to restore the anatomical facial projections and proportions and occlusion. Correct sequence of repair is critical to the successful outcome. Use subunit principles because that is the easiest to do, either bottom up or top down approach. Regardless of the approach, Lefort-1 repair should be done last. If I conclude the entire lecture, I would say that the life-threatening injuries take priority over facial fractures. Systematic evaluation is critical. Clinical examination plus CT scans, which are the gold standards, that will help you to avoid any injuries, avoid missing any injuries which are there. You understand the fracture patterns, just not only the bones. Mandible, midface, and the orbit and panfacial injuries follow predictable biomechanical patterns. You restore the functions before the aesthetics, occlusion, airway, vision, then the facial symmetry and contour. Occlusion is the key guide in the mandibular fractures. Always reestablish the pre-injury occlusion. And principles of fixation matter. Stable fixation, proper reduction, respect for the soft tissues envelope, Panfacial fractures require sequencing. You have to have a sequencing in these panfacial fractures, and subunit principles are the easiest and the most widely used panfacial sequencing. Early and well-planned intervention reduces the complications of deformity, and obviously, as said, that these fractures, if there is a multidisciplinary approach which involves the ophthalmology, which involves neurosurgery, which involves ENT, and collaborations whenever required, that will reduce the complications. The complications which are preventable, that they are the infections, malocclusions, diplopia, deformity, or meticulous planning. It can be reduced by meticulous planning and execution. Ladies and gentlemen, thank you very much for your patient hearing.
Thank you, sir, for the wonderful session that included pictorial presentations and a lot of practical informations. So the participants, they posted questions in between the session. I again request all the participants to please write questions in the chat box of the Zoom, and or they can unmute themselves, like if they want to ask question verbally. So there are 3 questions that have been posted in the chat box till now. So the first one is that in angle fracture, teeth in fracture line. So the concerned doctor, they want to ask regarding the considerations, whether we need to extract that particular tooth or need to retain. So how to decide that. So
yeah, that's a very relevant question. Thank you very much for that question. If the tooth is fractured, if the tooth is in the line of fracture, and if it is fractured, you have to remove that. If it is exposed to the fracture line more than 2/3, you have to remove that. If it is a cariously exposed tooth, you have to remove that. If it is hindering in the reduction, you have to remove that. And many times, if it is a mobile or already avulsed or luxated tooth, you have to remove that. Having said that, there are evidences which are available in the literature which suggest that keeping a tooth or not removing the tooth which is exposed, which is a healthy tooth which is exposed to the fracture line, does not really cause any problems. Should it cause problem in the coming follow-up 2 to 3 weeks, it can be removed easily. Many a times, while removing the third molar, which is there in the line of fracture, that reduces the entire fixation system from a load sharing to a load bearing, because you will lose some amount of bone there. So I think that answers that question.
Right. Thank you, sir. There is another question regarding Lafort. So the question is that if CSF leak happens in Lafort fracture, so should we delay surgery till CSF leak stops?
CSF leak is not a contraindication for any fracture fixation. In fact, if you fix the midface fractures, the CSF leak might reduce, might actually stop. Having said that, if there is a CSF leak which is diagnosed, you don't pack the nose, let the CSF leak go, let the leak go on, because any packing will cause retrograde infection and meningitis in these patients. So I would say that CSF leak is not a contraindication to fracture reduction in the midface.
Right. Thank you, sir.
Sorry, just come up. That can have an implication on the anesthesia, and then you need to have a submental intubation or a tracheostomy in these patients, because anesthetists are worried about putting a tube in the nose, especially when the CSF leak is there.
Right. So the next question is that though it is uncommon, that I read in my during my MBBS, that Lafort 3 is usually not managed conservatively, but still a question is asked in the chat box that can we treat Lafort 3 conservatively, maybe remote possibility. So there are maybe very few circumstances. So.
Yeah, everything depends on the energy of trauma. You see, if it is a low energy trauma which is causing non-displacement of the fractures, you can get a good occlusion, but at the same time you will have to fix the fractures to a stable point above the fracture line. I don't see there is any conservative treatment which is there, and many a times you see putting the patients into intermaxillary fixation is said to be conservative. But for me, it is a very, very radical thing. I mean, you tie my mouth for 6 weeks and I would say that I want to talk to another doctor, please.
Right, right. Thank you, sir, for clearing doubts. Another question posted by the participants is, sir, what's the best way to manage bilateral angle fracture?
Okay, bilateral angle fracture as such are very, very, very rare, and we do see them. So in case if there is a bilateral angle fracture, the entire biomechanics of the mandible is gone. Yeah, all the biomechanical studies and bench studies have been done on a linear angular fractures. Whenever there are two fractures which are there, at least one fracture should be treated rigidly. And the other fracture can be treated by means of a small monocortical fixation or a propeller plate fixation there. But many surgeons try to they tend to use the propeller plate bilaterally. But in these cases, these patients do require some kind of intermaxillary fixation or maxillomandibular fixation for some time. For me, I would treat one of the fractures rigidly by means of a bicortical plates, bicortical screws, and one fracture by monocortical by a propeller plate on the Champy's lines.
Thank you, sir. I still request the participants to ask questions. If well, they can also unmute themselves. They can just raise their hand. We'll unmute them. Another question which is posted now: if anyone is having extended teeth in lower jaw, then what we should do? Ma'am, is it regarding trauma or you can just unmute yourself, ma'am?
Yes, good evening, sir.
Yes,
If
please.
anyone is having extra teeth in lower jaw, only
Extra teeth,
single teeth, only single one.
only single
So
tooth.
is any there procedure to remove?
Is this regarding trauma or is this regarding something else, ma'am, please?
No, simple. No trauma, simple.
Okay, so if there is extra,
Inside,
if
not
there is
front side, inside.
if there is extra tooth, as in supernumerary or something, it is, and if it is involved in some kind of disease process or it is hindering in the occlusion or it
It
is.
is not disease. Excuse me, it is not disease. Only child is having one single teeth.
Ma'am, this is not really related to trauma, but you should remove them.
Ma'am, we will have another session for children. So now there is another question regarding, yeah. So sir, the another question that is been posted is how would we manage bilateral condylar head fracture if it is causing anterior open bite with posterior gagging of occlusion?
So bilateral head fractures seldom will cause anterior open bite or a posterior gagging because it is a head fracture. There are evidence available these days that that you can do a condylar head fixation as well by using some kind of bioresorbable screws or by means of titanium screws as well. But very rare to have a associated bicondylar head fractures, which is superior 4 to 5 millimeters. And in case if that kind of case comes to me, I would know that there is no derangement in occlusion. And should there be any derangement of occlusion, probably a elastic traction for about 7 days should do well with these patients.
Right. Thank you, sir. So I think there are no more questions. I still request if anyone else wants to ask regarding any question on facial trauma or related to oral maxillofacial surgery, so they can still unmute themselves and they can ask. Okay, so another question is there, sir, can splint versus sir caps, okay, cap splint versus or if in pediatric trauma patients. So what your opinion about it, sir?
Yeah, okay. Most of the pediatric fractures are either treated by cap splints, especially the mandible ones, are treated by cap splints. They work fine. That's not a problem in that. We tend to have a very low threshold of not treating patients with open the fractures and treat them. You can treat the pediatric fractures by resorbable plates, which are available these days. But the cap splints do very well. But cap splints require some kind of expertise in making the impressions, fracturing the mandible, and making the cap splints. If that kind of facility is available with you, that works fine. And you have to use circummandibular wiring nicely to put that splint in place. But children do very well with cap splints as well as with open reduction internal fixations. But the plates have to be removed in about 6 months' time.
Thank you, sir. Sir, there are two more questions posted on YouTube channel. So one is the difference in management between gunshot injury and comminuted fracture secondary to trauma.
Yes, the gunshot injuries will have a energy which causes a wide scale soft tissue problems, and you will need to have a lot of debridement, which continues over many days in these patients. However, a traumatic comminuted fractures, all you have to do is to just clean these areas, and in case if everything is fine, you can reduce and fix it at the same time. However, gunshot injuries would require some time till the soft tissue vascularity is maintained and the debridement is stopped. There is a continued loss of these fragments because of the long-term avascularity of these areas. Once everything is okay, then you can bone graft these areas, treat them. But the principles remains the same: reconstruction plate, rigid fixation, bone graft these areas.
Right, sir. So there is another question, sir. What shall be the cutoff period for after trauma for ORIF of various facial fractures?
If the fracture is not united, I don't see there is any cutoff period. There were some old studies that if you don't do the open reduction in few days time or few weeks time, then there is infective complications. But if the fracture is not healed, and whenever he has come, you can do the open reduction internal fixation. You can do some kind of freshening of the edges and do the fracture fixation. And if it is malunited, you can refracture that area, or you can do some osteotomies and still do fixation in these patients.
Right. Thank you, sir. Till the time we wait, okay, there's another question. Sir, please explain about the incision for different fractures in mandible and which is the best for specific fractures, as different books suggest different incisions regarding incisions for different fractures.
I think I have to be quick in this because there could be many incisions, but mostly if you look at the symphysis and parasymphysis fractures, the intraoral vestibular incision is the best. You give an incision onto the mucosa, and then you go 90 degrees and you cut the mentalis muscle there, and you go right up to the periosteum, reflect the bone, and you can see the fracture. That is the anterior intramental foramen fractures. If you go posterior to it, then you give incision at 5 millimeters below the attached gingiva. You go up to the periosteum, reflect that area, and that is, you can treat the body fractures. In the angle fractures, similar vestibular incision which goes onto the anterior border of the ramus of the mandible, expose the area, and you can fix these fractures. If you have to go extraoral, then a submandibular incision is best. For the condylar fractures, retromandibular transparotid incision is the one which gets you quickest to the condyles, and it has got variations of anterior mesenteric approaches as well. Whichever you are accustomed to do, you can do that.
Thank you, sir. So I think now it's time to get remarks from the chief coordinator of the series, Professor O.P. Garbanda, sir. Sir, over to you.
Am I audible? Okay.
Yes, sir, you are audible.
I think first of all, I must thank Dr. Ajay Rai Chaudhary for making such an complicated and big ocean of subject of maxillofacial trauma into a very presentable and simplified, yet not missing any point. Thank you very much. Because you have shared not just the principle, but the live case study, case report, practical experience, your approach, and which is very much appreciated. And I could see among the audience, there are very senior people. Many of them are principals and deans from AIIMS and other institutions. So this only speaks that how much Dr. Chaudhary's work is in demand as a specialty of maxillofacial surgery. He has many more subjects to offer to us. Maybe we'll use his expertise at some other time as well, and he will give us the opportunity to invite him. But with this, I think on behalf of each one of you who are listening to him and on behalf of National Academy of Medical Sciences, I like to thank him immensely for his presence, knowledge, contribution, and approach the way he has presented the complicated subject into a very simple manner. Thank you very much.
Thank you, sir. Thank you. Pleasure, sir.
Excuse me, sir, please 1 minute. Because I have discussed with few doctors, so they are saying ki no need to remove it. So that's why I want to know what is your opinion.
Thank you very much, ma'am. The thing is that we need to look at the patient, and if somebody has already seen him, you should take the advice, because
I
talking
show
like,
in the Lucknow.
yes, very
In the
good.
Lucknow, that one.
so
Where
so
teeth is day by day growing up.
you need to show it to somebody there, and then whatever opinion they give, you can see that. Thank you very much,
They
ma'am.
have given me
Thank
ki
you.
no need to remove it. That's why I want to know your opinion.
Ma'am, sorry, it is important to bring the patient, and seeing the patient will change many things. So you are requested to please bring the patient. This will help to make decision regarding management. Thank you, ma'am.
Okay, thank you.
Thank you. So thank you, everyone. I think there are no more questions, so we can now move towards the end. So now I request uh, Professor Ajay Kumar Sood, sir. Sir is the Deputy Secretary of National Academy of Medical Sciences. So over to you, sir, for the word of thanks. Thank you, sir.
Thank you, Dr. Jaswant. Again, on behalf of the National Academy of Medical Sciences, it is my great privilege, sir. You have been with us, and very nicely have covered a very complicated topic, as Professor Kavanda said. And we are grateful to you, and we look forward for your blessing in future also. Thank you so much for being with us. I also take this opportunity to thank Professor O.P. Karbanda, sir, who is our senior council member as well as a emeritus professor of the academy. He has taken great pains for designing this series on oral health and dental health. Thank you, sir, for your support to the academy. I also take this opportunity to thank all the participants, especially our faculty member and PG students who have joined this session. And the fact that so many questions were asked in this session, that itself says that this session has been very, very popular especially among the students and the faculty. And we look forward to your suggestion how we can improve this program further. For the information of the participant, the next session is due on 17th of April. And there again, we are going to a very interesting topic of restoration and rehabilitation of teeth. And there we have a principal of RPS Institute of Dental Sciences, Dr. Mirtha Hegde. She is going to take up this topic. And if you have any question related to this topic, you can always write to us, and we'll try to share it with the speaker so that this aspect will be covered in the next session. Another information is that AIIMS, NAMS in collaboration with ICMR has started online helpline, biostatistical helpline, especially for the PG student. If you have any question related to statistics, you can always use that helpline. And the details we have circulated in the chat box. And these details are also available on the website of NAMS as well on the ICMR. And those of you who are computer savvy, and nowadays artificial intelligence is a coming up area. So NAMS in collaboration with the IIIT Hyderabad has started the 12 weeks online program on artificial intelligence in health. And just now we have finished the third batch, and the fourth batch registration is currently open. So if you are interested in this program, you can just log in to IIIT site or even website of the National Academy of Medical Sciences. And we have also circulated the details in the chat box. So you can kindly make use of that. And again, we have detailed activities of National Academy in the form of booklet, which we have again shared with the participant in the chat box. So that gives the details of CME program, which we sponsor, as well as we have fellowship for the research for PG students from Northeastern state, as well as for the young faculty members, and membership details. All these are on the booklet which we have circulated. So once again, I thank the moderator, Dr. Jaswant, for being with us. You have been helping us from the very beginning. Thank you for your support and time. Here in National Academy, we have Mr. Ravi, IT officer, along with Mr. Shivam. He has been helping us in organizing this session on the Zoom as well as on the YouTube. And the recordings are again available on the YouTube as well as on the website. So if you have missed some part of it, you can always refer to the video link, which is there on the website. And also we have a YouTube channel, NAMS YouTube channels. So once again, I thank you all for being with us and making this session very, very interactive. Over to you, Dr. Jaswant.
Thank you, sir. And thank you again for the interactive session. So I think with your permission, we can mark the close of the session. Thank you, sir.